Hi, everyone. My name is Erica Mulcaire-Jones. I am one of the rheumatologists. Let me just share my screen real fast. Okay. Is the main, you guys can see the main screen? Okay, perfect. I'm getting nods. Yes. So I'm one of the rheumatologists. I work in the scleroderma program here with Dr. Khanna and Dr. Zahn, and also do the CTD ILD clinic from the rheumatology side. So with Janelle and David and Justin, as well as I see a lot of patients from kind of all the ILD docs. And Sarah Brown invited me today to speak some more about CTD ILD from the rheumatologist's perspective. All right, so I have no disclosures. Feel free to stop me at any time, but the agenda for today, we're going to go over a couple of the main diseases and recognizing some of the common symptoms in ILD presentations from some of the most common connective tissue diseases that we see associated with interstitial lung disease. So rheumatoid arthritis, scleroderma, myositis, and Sjogren's. We're going to talk a little bit about lab interpretation and testing in this patient population, and then kind of ANAs in general, because I think that's one of the main questions that we always get as rheumatologists is when should I be worried about an ANA? And then we're going to spend just a couple of slides on treatment overview, and I'm happy to talk about that more afterwards or answer questions, but spend most of the bulk of the time on the first two objectives. All right. So we're going to start with an overview of a couple of the connective tissue diseases that we treat. So we'll start with rheumatoid arthritis. So rheumatoid arthritis is our most common rheumatic disease that we treat in the rheumatology clinic. Incidence is about, I usually tell patients about 1%, so 1 in 100. So when I give similar talks to medical students or residents, we're often very focused on is lupus causing someone's symptom, talk a lot about type 1 diabetes, psoriasis, but rheumatoid arthritis is actually more common than all of these. And so everyone is going to see some patient with rheumatoid arthritis in their clinic at some point along the road. The most common symptoms are polyarticular joint pain and swelling. Most common joints to be involved are the small joints in the hands, so the MCPs and PIPs, as well as the wrists. The analogous joints in the feet can be involved as well, and certainly patients can have large joint involvement also. So if it's on one side in the wrist, it's often on the left side in the wrist as well. Morning stiffness, it typically lasts longer than 30 to 60 minutes. This is different than osteoarthritis, where people may have some stiffness in the morning, but it typically lasts than 30 minutes. Many of our studies with rheumatoid arthritis include morning stiffness lasting longer than 60 minutes because that's more specific for inflammatory disease. And then symptoms based on the criteria should be lasting longer than 6 weeks, although sometimes now with testing and patients presenting earlier, we do diagnose it earlier. And that cutoff really is because post-infectious arthritis is often self-limited and resolves on its own without treatment in less than 6 weeks, whereas rheumatoid arthritis is not going to go away and so lasts longer. Symptom-wise, there's progression of symptoms from early mild swelling to more severe swelling to eventually joint damage. And we really see this mimicked in many patients' x-rays as well. So early in the disease, if you get x-rays as an A, you'll often see a normal joint. So it's got a nice kind of white border. There's no breaks in the border. And then you see the black, which is the air. So the space in between the joint is really well preserved. Some of the earlier changes, we'll see periarticular osteopenia, so some bone loss or like thinning of the bones next to the joints that have inflammation, and then joint loss. And then eventually you'll start to see these periarticular erosion. So erosions right next to the joint. Looks like they've had a bite taken out of it. We can see a wide variety of deformities in the hands in people who have more long-standing joint disease, as well as patients who have more aggressive joint disease as well. Unfortunately, we don't see a lot of these changes anymore because we have much better treatments than we used to, but these used to be really common to see in patients. So swan neck deformities are it's due to damage of the extensor tendon over the MCP. Boutonniere deformity is similar, but due to damage of the extensor tendon over the PIP. ulnar drift is where the fingers kind of point to the side, and that's due to subluxation of the MCP joints. And then we often will see rheumatoid nodules, and these feel kind of rubbery, and you can kind of move them as opposed to like tophi or osteoarthritis, where they'll feel more hard and fixed. And then while we know that rheumatoid arthritis certainly affects the joints, it can affect many organs outside of the joints. And I think these tend to be ignored a little bit more, but we screen our patients for a lot of these symptoms in clinic. Obviously, we're here talking about the lungs, so we can see a wide variety of lung disease, including effusions, rheumatoid nodules in the lungs, which can be difficult, look a lot like malignancy in some patients and sometimes need to be biopsied. Interstitial lung disease, and then vasculitis as well, though that's less common in rheumatoid arthritis. We know that rheumatoid-associated ILD occurs in a fair number of patients. So we see if you screened kind of random patients that came into clinic, about a third would have subclinical disease. But a far less, so only about 10% of patients will develop any clinically significant lung disease. There's currently no screening recommendations in terms of who we should be getting CTs or pulmonary function tests on. There are some studies that we're actually currently involved in that's trying to take high-risk patients and see which of those patients might benefit from screening. Some risk factors for lung disease include male sex, history of tobacco use, and then high positive serology, so CCP or rheumatoid factor. Patients who have other extra articular, so non-joint disease manifestations such as scleritis or secondary Sjogren, so dry mouth, dry eyes related to their rheumatoid arthritis, vasculitis, are also thought to be higher risk for getting lung disease. Why is this important? The average survival, depending on what study you look at, is 2 to 10 years after the diagnosis of ILD. We have seen a lot of gains in terms of how patients are functioning and surviving in terms of rheumatoid arthritis in general with all the new biologics that we have. But lagging behind that is our RA-ILD, and with our ILD patients, we actually have not seen an improvement in mortality despite kind of having more treatments available. And then once you diagnose ILD, some risk factors for kind of negative outcomes include lower FVC and DLCO, extent of fibrosis on CT, and then higher disease activity in terms of how many tender and swollen joints a patient has and how well their RA is controlled overall. Some studies have suggested that UIP is associated with a worse prognosis, but there have been Solomon et al., they looked at patients who had UIP and then controlled for smoking status as well as some other variables. And they actually found that there was no difference in survival between UIP and NSIP. So kind of pattern, probably less significant in terms of prognosis. All right, so we're going to move on now to a little bit of review on systemic sclerosis. So scleroderma is an autoimmune disease. It's characterized by vasculopathy, inflammation, and fibrosis of the skin and other internal organs. It has the highest mortality of any of our rheumatic diseases. And the incidence, it varies quite a bit depending on which population you're looking at. I usually quote people at 6 to 8 per million persons. And then the most common time to develop scleroderma is females in their 40s and 50s, but if we see it from pediatric through kind of older ages as well. Time to diagnosis of scleroderma is often longer in females, and part of that is males tend to have a more kind of robust onset to their skin disease, and then so women, it may take longer for people to notice their symptoms. And then there's probably also some bias about women kind of complaining about cold hands or musculoskeletal symptoms that don't get taken as seriously at first. We characterize scleroderma in 2 different ways. So, and this really helps us tell what symptoms or organ complications patients are going to be most at risk for. So first is by skin involvement, and then we also characterize people by the autoantibodies that they're positive for. So we have 3 main types of skin involvement in systemic sclerosis. So limited, diffuse, and then systemic sclerosis, synapse sclerosis, which means that they have internal organ involvement, but no skin disease. So limited disease patients, they can have skin involvement below the knees, below the elbows, and then it can involve the head and neck. This picture is a little bit confusing. It doesn't actually include the chest or the torso. These patients are often centromere positive and what we used to refer to as crest syndrome, but we don't use that term anymore because we know that diffuse patients can get calcinosis, they can get Raynaud's, they can get really severe esophageal dysmotility and other GI complications. And so it just wasn't a really accurate way to divide patients. So now we call it limited. These patients often have Raynaud's that can start up to a decade before their other scleroderma symptoms start. And then commonly pulmonary, or I should say pulmonary hypertension is a relatively common late complication. And then PBC can occur later in these patients too. Diffuse patients can have involvement of the skin basically anywhere on their body. It still typically starts in the hands and then moves up proximally. These patients are often positive for SCL70 and RNA polymerase 3. RNA polymerase 3 is associated with this like really robust, like rapid skin changes with really severe skin disease. Often the Raynaud's in these patients occurs within 1 year of the skin changes or at the same time, around the same time that the skin changes start. These patients can have a lot of more significant internal organ involvement, including interstitial lung disease, scleroderma renal crisis, myocardial inflammation or fibrosis, and then bad GI involvement as well. And then patients without skin disease, I think, we don't think of them as often, but this can actually occur in up to about 1 in 10 patients. So we see quite a few of these patients in our clinic. And again, because they don't have the classic skin findings, diagnosis is often delayed in this patient population. So we also, in addition to skin, we think about patients' autoantibodies when we're thinking about scleroderma. So the 3 main antibodies that are in the American College of Rheumatology criteria for scleroderma are the SCL70 or topoisomerase. This is associated with lung disease. So these are a lot of the patients that you guys are seeing that have more progressive interstitial lung disease over time. RNA polymerase 3 antibodies, they can have lung disease, but it tends to be more limited and not as progressive. Notably, these patients are much higher risk for scleroderma renal crisis. They have that really bad skin disease. And then it is also a paraneoplastic association. So about 1 in 5 patients can have we detect a cancer that might be triggering their scleroderma to occur. Centromere patients, again, their ILD tends to be more mild and less progressive, but certainly people break the rules. And then they tend to be associated more with pulmonary arterial hypertension. Other antibodies that we can test for, you can get on the myomarker include the PM-SCL100 antibody that can be an overlap with myositis, a COO antibody, which again can overlap with myositis, and then the SSA or Rho52, which SSA antibodies can be directed against 2 parts of the protein, a 52 kilodalton and a 60 kilodalton subunit. And the 52 kilodalton, regardless of which connective tissue disease, whether it's Sjogren's, lupus, rheumatoid arthritis, if they test positive for that 52, that increases the risk of and progressive ILD in many patients. And then we do have about 10% of patients that are ANA and antibody negative. So like everything in rheumatology, nothing is exact. And so there are always patients that are breaking the rules. Okay, in terms of natural history of scleroderma, we see 2 main trajectories of disease course. So limited patients, these are the red line. So their skin disease tends to be a little bit slower, progressive, and kind of plateau over a couple of years. Whereas diffuse patients, the skin disease tends to have this rapid takeoff in the first couple of years, particularly in the first 5 years, and then the skin will soften over time. People will still be left with, the skin never returns to normal, and people can be left with a lot of damage and contractures. But if you feel the skin, it actually tends to feel like kind of thin, or we describe it as atrophic later on. Most of the internal involvement, including interstitial lung disease, tends to occur in the first 5 years after a patient's disease starts. And we define that start as a patient's first non-Raynaud's symptom. So because we know that Raynaud's can occur up to 10 years before other symptoms start, the first symptom after their Raynaud's is really where we set like the start date for someone's disease in scleroderma. So some of the skin changes that we are looking for in scleroderma. So the classic thing that we think about is sclerodactyly. So this is the kind of puffiness and thickness of the skin in the hands that leads to tapering at the end of the fingers. People will get classic changes of the face, including thinning of the nose and the lips. They will often lose their wrinkles in the cheeks and kind of make their skin look more taut or younger. These tend to be a little bit later, but early on, which I think is, what a lot of clinicians miss, is that patients may not have a lot of skin thickening early, but they'll present with what we consider like puffy fingers. And the skin may or may not be thickened depending kind of on the individual rheumatologist assessment, but the whole finger will feel kind of puffy and swollen. It doesn't change with the time of the day. And what we ask patients in clinic is, are you able to get your rings on and off? And if you can't get them on and off like you used to, or if you've had to resize your ring, is that persistent all the time? And patients with early scleroderma will often answer yes to that. And then later in the disease, we'll see more of this, these patients with contractures, and then they have more atrophic and what we call tethered skin. So the skin has been damaged and stuck down to the tendons. So if you try to pinch the skin, you can't peel it up very well, but it doesn't actually feel thick like it did in the early stages. We can also see other skin changes that we often refer to as salt and pepper changes. This tends to happen early in the disease in diffuse patients, and they can get both hypo and hyperpigmentation of the skin. They'll lose pigment, but retain the pigment around the follicles, leading to kind of this classic appearance. Raynaud's is also common along with digital vasculopathy. So Raynaud's is triphasic color changes of the fingers in response to cold. So white, blue, and red color changes in response to cold or emotional stress. In scleroderma, patients get a lot of chronic damage to their fingers. And so we can see this middle row of pictures called pitting. So these are kind of early or partially healed ulcers. A lot of times the pitting never completely resolves, and then patients can get full thickness or open ulcers of the fingers as well. And that can be digit threatening. They can get infections and osteomyelitis. So we take that really seriously. And then they can get fingernail changes as well with thickening and kind of curved ends of the fingernails that kind of grow into the skin and can be pretty difficult to treat. Tissue loss is one of the hallmark features in scleroderma compared to other causes of Raynaud's, but we don't see that in every patient. So patients who don't have this pitting or ulcers, we can actually perform a nail fold capillaroscopy in clinic, and this is essentially using a microscope to take pictures of the blood vessels in the fingernails. So normal blood vessels should look, I just tell them to patients, it should look like a bobby pin. They should be relatively straight and thin. Early in scleroderma, we'll start to see that they get larger. And then you can start to see some bleeding where there's been damage to the vessels as well. And then later in the disease, once the vessels have been damaged, you'll start to lose the vessels, and we call that, there'll be empty areas, and we'll call that dropout. And then the body tries to repair itself by growing new blood vessels into those areas. And so we'll see this neoangiogenesis, and we call them bushy capillaries because they don't grow back in normally, and they kind of have these multiple tufts. One of the most important things is to recognize primary versus secondary Raynaud's. We've already talked about some of the features of secondary Raynaud's, but primary Raynaud's is an idiopathic, essentially vasospasm of the blood vessels. This is typically not due to any, or this is not due to any underlying disorder, whereas secondary has some sort of trigger for the Raynaud's. So there are some pretty simple questions you can ask patients in clinic to try and sort this out, because a lot of patients come in and tell you that they are having color changes of their fingers in the cold. But less worrisome Raynaud's tends to start at an earlier age. So we often think of females between the ages of 15 to 30, whereas if Raynaud's starts after the age of 30, or especially if it starts after the age of 40, there's something else that is triggering the Raynaud's. Primary tends to be symmetric, secondary can be symmetric or asymmetric, so one hand or both hands. Primary symptoms tend to be mild and relatively stable over time, so not getting worse. Whereas secondary Raynaud's, especially in scleroderma, you can see that pitting or tissue loss, and then their symptoms tend to get worse over time. And then interestingly, in primary disease, I will ask patients if their thumbs are involved. If there's no thumb involvement, that's more likely to be primary. If there is thumb involvement, then there's typically something triggering it. And then there are many, many causes of Raynaud's. So we often think about the connective tissue diseases as being a cause of Raynaud's, including scleroderma, lupus, Sjogren's, they can all cause it. But there are certainly many medications that can contribute to Raynaud's, any amphetamines, including Adderall. I've seen multiple patients who have been started on, Vyvanse in their 30s, who come in with new Raynaud's because of vasospasm due to the medication. Chemotherapies, I didn't put beta blockers on this list, but beta blockers, anything that can cause a vasospasm. Hematologic abnormalities, including paraproteinemias. So a lot of patients, we will check an SPEP. There are multiple occupational environmental exposures, including carpal tunnel syndrome, vibrational tool use. So screen for occupations and hobbies. So people who are construction workers or a lot of people who are doing woodwork, that they use a lot of vibrational tools and that can damage the nerves and cause Raynaud's. And then there's a bunch of other associations, including hypothyroidism, fibromyalgia, burgers, and then smoking as well. We do have a Raynaud's clinic. So if anyone has a Raynaud's patient, you are not sure if you think they have some secondary characteristics, but you cannot figure out what their Raynaud's is due to, you can always send them to our Raynaud's clinic, which is staffed by Carly Zahn. She's in the scleroderma program as well, and she will do a full assessment, capillaroscopy, and kind of help sort out if the Raynaud's is worrisome, not worrisome, and maybe what's triggering it. Okay, so other symptom screening in scleroderma. So we talked a lot about the musculoskeletal manifestations. If patients think that they're later, then looking for pulmonary hypertension manifestations, including edema, dyspnea similar to ILD, looking for any vascular disease, so Raynaud's, telangiectasias, and then men, it's pretty common to get erectile dysfunction as well, and that's due to the vasculopathy also. Patients can't or myopathy, so looking for proximal muscle weakness, inflammatory arthritis, calcinosis, which is hard calcium deposits under the skin that are typically, that can be painful. Many patients get GI involvement. So most of our patients have reflux. Many also have dysphagia, and it's the smooth muscle in the esophagus. So patients will feel like they're getting food stuck behind the sternum because it's low down. And then there's a lot of patients can get other gut involvement too. So bloating, constipation, and diarrhea are common. And then our patients that are at risk for renal disease. So we screen for hypertension and symptoms of malignant hypertension as well. So scleroderma associated ILD, most common pattern is NSIP. There is a high prevalence of ILD in scleroderma patients, depending on what study, usually 30 to 60%. I usually tell patients about 50 to 60% of patients will develop some ILD, but not all of this is clinically meaningful. ILD is responsible for about a quarter to a third of scleroderma related deaths. And we know that the 10-year survival decreases quite a bit once you're diagnosed with ILD. So it goes to 30 to 70%. Risk factors for ILD include being a male, really diffuse skin disease, that positive SCL70 antibody, significant reflux or dysphagia, probably due to microaspiration and causing additional damage to the lung, smoking, extent of disease at diagnosis, and then African Americans tend to have worse lung disease. So who do we treat? So we treat patients with extensive disease, patients who have evidence that their lungs have already been impaired. And then I will offer treatment to patients who have less extensive disease, but they may have some risk factors for progression. So being a male, having early diffuse disease, and then having a positive SCL70 antibody, even if their ILD is mild, I'll often offer them immunosuppressive therapy for that alone. Whoop. Okay. So we're going to switch to talk a little bit about myositis. So we call this group idiopathic inflammatory myopathies. It's a really heterogeneous group, and we're really going to focus on the subtypes that have the highest risk for lung disease, which is this middle group here. So that's the patients with antisynthetase syndrome and then MDA5 positive antibodies. So we'll look at those two groups. I'm not going to talk about the PMSCL group so much because they typically have an overlap between dermatomyositis and scleroderma features. And I usually treat them based on which they look more like in clinic. So we know that different antibodies in myositis confer different levels of risk for ILD. So our very high risk antibodies, so MDA5, which we will spend some time talking about, and then some of our antisynthetase antibodies. So the EJ antibody, some studies report 90 to 100% of their patients developed some level of ILD when they had that positive antibody. PL7 and PL12 have been historically kind of the highest associated prior to knowing about EJ with ILD. So those are high risk as well. We have some more kind of moderate to high risk antibodies, and then we have some antibodies that are much lower risk for developing ILD. We also see two distinct phenotypes in myositis and ILD. So we have some patients who have more of a chronic course. These patients do have decreased survival. Mortality is about 21% at 5 years. Whereas patients who have rapidly progressive disease, and there's not a formal definition from study to study about what rapidly progressive means, but it's typically worsening either by symptoms, decrease in FVC or DLCO, or extent on CT over a 4 to 12 week period, depending on the study. But these patients tend to do a lot worse, and the mortality is 50% at 5 years. So antisynthetase syndrome is that first big group of antibodies that we saw. These are antibodies that are directed against tRNA synthetases in the cell. There's not a formal criteria that any one person uses, but there's some common clinical features, including interstitial lung disease, arthritis, Raynaud's, fever, and mechanics hands that many patients will develop in addition to having myositis, although not all patients will have muscle disease associated with this syndrome. The classic triad of what we consider antisynthetase syndrome is arthritis, myositis, and ILD. But we actually only at diagnosis see that kind of all three features in 15% of patients. Over time, over a couple of years, having all three features is seen in almost half of patients, but certainly still not all. So there's some fluidity on kind of how patients meet the criteria for antisynthetase syndrome. So this is an example of what we're looking for when we are saying someone has mechanics hands. So it's described as hyperkeratotic fissuring, scaling, peeling of the skin on the fingers or toes. And it looks like someone's had kind of like a chemical or occupational exposure that's causing changes to the skin. It's typically kind of along the sides of the fingers, can be on the palms or soles of the feet as well. Some changes can be a lot more mild. Some people will mistake this as like ulcers related to Raynaud's, but they're, if you look at them, if you're used to looking at them, it will look a little bit differently, although sometimes it can still be hard to tell the difference. Patients can also get other findings that we classically think of as being associated with dermatomyositis. So Gaucher's signs or papules is this red, kind of scaly, plaque-like rash that extends over the joints and the backs of the fingers. This can look a lot like there's lupus rashes that look similar, although the lupus rashes don't involve the joints, whereas dermatomyositis does. Shawl sign, which is over the back of the shoulders in the location a shawl would go. A V sign, which is often in almost a V-shaped, like a t-shirt on the neck. Holster sign on the sides of the thighs, and then many people remember kind of the heliotrope rash, so that's rash over the eyelids, can extend onto the cheeks and face, and can look a lot like a lupus, like malar rash as well. So and actually, if you go to biopsy these rashes, the biopsy will show interface dermatitis, which is the exact same finding that you'll see on a biopsy in a lupus patient. So based on biopsy, you can't tell the difference between skin rashes from dermatomyositis and lupus, but they have some kind of clinical features that can be a little bit different, but in some people overlap. Interstitial lung disease and antisynthetase syndrome can involve, again, a wide range, percentage of populations. It really, the risk depends on your individual antibody. Again, EJ antibodies have the highest risk, followed by PL7 and PL12. We see a lot of Jo1 positive patients as well. Jo1 is the most common antisynthetase antibody. It occurs in about 1/4 to 1/3 of patients with antisynthetase syndrome. And the prevalence of ILD, depending again on the study, is quite variable. Notably, these patients can have quite severe acute ILD as well. I have a couple on my panel now that have been hospitalized kind of multiple times, required ECMO, given the kind of rapid severe progression. But thankfully, they tend to be more immunosuppressive responsive. NSIP is the most common pattern, followed by organizing pneumonia and an overlap between NSIP and organizing pneumonia. And then similar to our kind of other ILDs, risk factors for progression include African-American race, actually absence of malignancy, and then patients, again, who have addition to their antisynthetase antibody who are also positive for that SSA 52 kilodalton. And then just 2 quick slides on MDA5 positive myositis. So these patients get really sick. They have very life-threatening, rapidly progressive lung disease, even with upfront very aggressive treatment, including pulse steroids and starting multiple immunosuppressives at once. Mortality is 50 to 60% at 6 months. So our goal is to recognize these patients early and treat them very aggressively upfront and then back off if they are doing well. Often these patients are actually amyopathic, meaning that they lack muscle disease, and then they can have some very specific skin findings, including ulcerations on the kind of the extensor surfaces of the hands, can occur on the feet, and kind of other extremities as well, but kind of on the back of the hands is the classic one that that's described. They can get other rashes, including mechanics hands and other rashes that we looked at in dermatomyositis. Although we often think of these patients as doing really poorly, we know that this group of patients is also a spectrum of diseases, and there's been some work to classify these patients into different phenotypes. And so there are patients who seem to have a lot lower risk for mortality and rapidly progressive ILD. These tend to be women. And if you present with arthritis or arthralgias as part of your kind of complex of symptoms, you tend to do much better. Whereas patients who present with mechanics hands tend to do much worse. The patients that have those ulcers or skin vasculopathies tend to be men and have kind of mild muscle disease. They have a course that's still not great, but more middle of the road.
I have a question about acute presentations of lung disease in these syndromes. So is the thought, especially you mentioned like patients who've had to have ECMO you had a patient who had to have ECMO with anti-Jo1, is the thought that there's like an acute inflammatory condition that's going on that could potentially be reversed and that you could recover from? Or is the idea that there's like fibrosis and other potentially irreversible things going on that you just need to arrest before they get worse?
I think it's probably some of both, and some of the ILD kind of pulmonologists can chime in too. I mean, certainly some of these patients have really bad organizing pneumonia, and that tends to be, they need prolonged steroids, but I feel like they often do better over time. And then some of these patients, like the MDA5, they get really bad, like I didn't put any pictures in here, but extensive fibrotic disease. And so if you can catch it early before they develop that really extensive disease, then that can be helpful for them. So I think it's probably a combination of both, and it really depends on the underlying kind of like their lung presentation, what subtype they fall into.
Thanks.
Okay, this is a question that always comes up when we talk about dermatomyositis, because I think classically associated board questions is that it's associated with malignancy. So patients with ILD actually have a lower incidence of malignancy compared to other dermatomyositis patients, but the risk is still above kind of the general population. Incidence of malignancy in dermatomyositis and polymyositis ranges between 5 to 10%. 10% being more of kind of the dermatomyositis patients and 5% probably being closer to the polymyositis patients. The types of malignancies that we see often mirrors the incidence in the general population, but notably there's a higher risk of ovarian, pancreatic, and gastric cancers in this population than in the general population. And what we think is happening similar to other perineoplastic processes is that the tumor cell is expressing an antigen that's the immune system is recognizing that antigen and trying to clear the tumor cells. And by doing that, makes autoantibodies that then recognize antigens in the host cell and ultimately cause damage. So for example, TIF1, which is associated with malignancy, is expressed at high levels in ovarian cancer. And so that's recognized. And then there's TIF1 in muscle cells as well. And so that's then recognized by the immune system and causes inflammation and destruction. And then that destroyed muscle actually increases their production of the autoantigen, leading to inflammation and damage. We have antibodies that are overall lower risk for malignancy. So again, those are the antibodies that most of you are seeing as pulmonologists. And then we have two antibodies that are higher risk for malignancy. So that's NXP2 and TIF1 gamma. There's no standardized approach to screening patients with dermatomyositis and polymyositis. In low-risk patients, I always make sure they have age-appropriate cancer screening. We've typically always checked a CBC, liver enzymes, and a UA, but you can consider a fecal occult blood if someone's not otherwise due for a colonoscopy. Some people recommend a chest X-ray, although certainly our ILD patients, they've already had a CT. And then kind of variable depending on the patient's risk factors for ovarian cancer. But many women will also order a pelvic ultrasound and a CA-125. High-risk patients, again, we make sure they're up to date on their cancer screening. I always do a CT chest, abdomen, pelvis on these patients, if not a PET scan. PETs are obviously harder to get from insurance, but patients who have a lot of weight loss, fevers, night sweats, although that might be due to the myositis, if they're high risk, then we might petition their insurance for a PET instead. And then all of these patients, I also get a pelvic ultrasound and a CA-125, or I guess all of the female patients, I should say. All right, I'm going to spend just 2 slides on Sjogren syndrome because we see a bit less of this. But prevalence of Sjogren's is about 0.3 to 1 per 1,000 persons. We often divide symptoms into exocrine dysfunction and extraglandular features. So exocrine dysfunction is inflammation of the lacrimal and salivary glands leading to dryness, and often we call that keratoconjunctivitis sicca when it's involving the eyes. Extraglandular features can involve most organs in the body, and about 1/3 of patients will develop some sort of extraglandular symptoms. These patients are also higher risk for malignancy, so their lifetime risk of lymphoma is 35 times the general population, and overall lifetime risk of a B-cell lymphoma is 5 to 10%. Most of those are MALT lymphomas. Lung involvement occurs in about 15 to 20%, although again, severity is very variable. Although we often think of LIP as being the kind of classic lung disease that presents in Sjogren's, it's actually not the most common form of lung disease. NSIP is more common, and LIP only makes up about 5% of the ILD cases in these patients. Risk factors for progression of their lung disease. So lip biopsy, we give what's called a focus score. I'll show a picture on the next one. So if they have a high focus score, or again, if they have specifically that 52 kilodalton SSA. This is on the right is a picture of the lip biopsy. And so they're looking at the glands and they're looking for foci of lymphocytic infiltrate. And so each of these foci is one. And so you can get points based on how many you see in a defined area. So patients who have a focus score of greater than 1 or a positive SSI antibody with dryness can be classified as having Sjogren's. Okay, I'm going to jump a little bit, switch gears and jump in more into lab testing. We'll spend the bulk of our time talking about ANA testing. So someone sent an ANA, not me, and it's positive. What do I do with this result? And probably a lot of the time the ANA testing will actually be used, since you're seeing all the ILD patients and kind of the front lines for screening some of their for other symptoms of connective tissue diseases. So what is an ANA that you are ordering? So this is an anti-nuclear antibody, and really the goal is to detect antibodies directed against the antigens in the nucleus of our own cells. So ultimately, we were trying to identify patients that might have an underlying connective tissue disease. And this is, sometimes people refer to it as kind of like a screening test, although it gives us more information than that. So there's multiple ways of testing an ANA. The gold standard is our indirect immunofluorescence, or IFA. And this is really the one we want everyone to order in the EMR, because it has it's more sensitive and specific than other methods of testing. And what they do is they take a patient's serum, they plate it, they add ANA antibodies, it sticks to the cells, and then they add a second detector, and then it's automated now, but either a person or a machine looks at it and it tells how much basically it lights up at different dilutions, and then gives a pattern for if it lights up what it looks like. So again, this is our gold standard. And the additional information from this is, again, that titer and pattern is really helpful for us in interpreting them. There are also solid phase assays. So these are ELISA and multiplex bead assays that can detect ANAs. They're done a little bit differently. The top ones in ELISA, basically they put antibodies at the bottom of a cell. So this is like an SSA antibody. And then you add the patient's sample or serum to it. It might stick to the antibodies, and then you add a second detector. And if it lights up, you say, yes, there is an SSA antibody there, or an ANA antibody there. Multiplex bead assay is pretty similar, but it's got coated beads and there's multiple wells. So you can test for 8 to 10 autoantigens all at once. So that's that, like ENA 10, you're testing for all 10 different things. Problem with is we do see a lot of false positives, because you can get denaturing of proteins that then stick and light up that aren't accurate. And it also, when we think about ANAs, there are a lot of autoantigens that we're not putting in the cell. So there's over 100 autoantigens that you might see by IFA when you're doing that assay, but you're only going to test for the specific 10 antigens that you put into the cell on the multiplex bead. So you're going to miss some positives, but you're also going to get some false positives. So false negatives and false positives. So I think if you take nothing else away from this talk, when you're ordering an ANA, you should order the indirect immunofluorescence, or IFA, and I'll show you what that looks like in the chart. So when we interpret an ANA, we look at the titer and we look at the pattern. So many healthy adults can have a positive ANA, and so the lower the titer, so the less they dilute it, and it's the more they can dilute it and it's still positive, the more specific for some underlying disorder that is. So many labs used to report a titer of 1 to 40, but it was not very helpful, because 20 to 30% of healthy adults will test positive on that test. And so it really doesn't help you determine who has a connective tissue disease versus who doesn't. So current ACR criteria for lupus require that the titer be at least 1 to 80. This is what the minimum that most labs will report now. You can still see 10, I tell patients about 10% of healthy adults can have a positive ANA at this kind of low titer. So having a positive ANA does not mean that someone has a connective tissue disease. We can also see higher titers in patients who are healthy relatives of patients with lupus and other connective tissue diseases. And then many patients, as they get older, will develop a positive test as well. The second thing we're looking at is the pattern. And so this is telling us maybe how the cell lights up. We can get either nuclear or cytoplasmic patterns. Nuclear patterns is what our lab reports. Our lab technically does do the cytoplasmic pattern, but it's not reported at this time, although that might be changing. And And why that's important, certain patterns are associated with certain diseases and certain antibodies. So if you're ever curious, I think for both nuclear and cytoplasmic patterns, ARUP, which is a reference laboratory in Utah where I trained, they have a really nice flow chart of kind of associated patterns with specific diseases. Okay, and then just because you have a positive ANA does not mean that you have a connective tissue disease. So certainly ANAs are seen with many of our connective tissue diseases over on the left, but they're also seen in other autoimmune diseases, including autoimmune thyroid disease, such as Graves and Hashimoto's. They can be seen in APS, they can be seen in MS, inflammatory bowel disease, ANCA vasculitis, autoimmune liver disease. So again, can pop positive for a variety of reasons. We can also see them positive in malignancy, particularly lymphoma and other perineoplastic processes. We never want to miss an infection when someone has a positive ANA, especially someone who comes in with fever of unknown origin. We're always looking for endocarditis, TB, syphilis, and then viral infections are common as well. And then again, there's multiple medications, can cause a positive ANA. It's seen in some patients with IPF, healthy adults. So this is kind of I don't know, one of the hardest parts about ordering an ANA is then kind of figure out how you're going to interpret it. So I always tell people it's kind of a piece of the puzzle, but it's does not give a diagnosis, nor does it break a diagnosis. I think we also get this question, can someone have a negative ANA and still have a connective tissue disease? And the answer, like anything in rheumatology, is yes. There's lots of reasons we can have a negative ANA. There are some diseases that have a negative ANA. So for example, Sjogren's, SSA antibodies can be cytoplasmic rather than nuclear. So if your lab like ours is not reporting that cytoplasmic pattern, it might flag as the ANA being negative when really it was actually positive. Many of the myositis specific antibodies may not have an ANA, so you want to order those separately from your ANA and not depend on the ANA being positive to trigger reflex ordering of that. Some patients become ANA negative with treatment. In lupus patients with severe proteinuria or on dialysis, often their ANA will go away. And those are kind of the most common reasons. So how do you order it in Epic? So this is, if you type in ANA, this is what will show up. So this top one, so the ANA by IFA is what you want to order, and then you want to go on to order your more specific antibody testing that you want based on your kind of clinical suspicion. The middle, the ANA antibody order panel, this may be going away, but it essentially sends the ANA by IFA, and if it's positive, it will give you the titer and pattern still, but it'll also reflex then to send an ENA 10 and double-stranded DNA. That one's okay to order, but if you're really concerned someone has a connective tissue disease or Sjogren's, again, SSA can be cytoplasmic, and so we as rheumatologists order our ENA separately from the ANA because we want both tests, not just to reflex. And then we still have this antibody screen. So this is doing it by an ELISA. And if the ELISA flags positive, then it will send it for an IFA. Never order this test. There's false negatives, false positives. So really the IFA is the way to go. I'm not going to go through this in detail, but just so you have it, some other studies to order in suspected connective tissue diseases. All patients, we get an ENA myomarker, rheumatoid arthritis serologies, and then consider ANCA and RNA polymerase antibodies as well. But there's other suggestions if you're suspicious for a specific connective tissue disease. And then just a couple helpful hints with other antibodies. So just a reminder, rheumatoid factor is also not specific for rheumatoid arthritis. We have this whole list of things that can cause a positive rheumatoid factor. C much more specific. So I just kind of awareness, we're happy to see these patients who flag as positive, but rheumatoid factors is we can see in healthy adults, and also chronic infections. SCL70 in our lab, our internal SCL70 has a high rate of false positives, so it actually gets reflexed to a testing cascade. So if this flags positive on the ENA, that does not mean that the patient has a positive SCL70. It will get reflexed to an ELISA, and then if that is positive, it will get reflexed to an immunodiffusion. So really you want to wait for this immunodiffusion to come back before you decide that the SCL70 is positive, and it will show up kind of sequentially over the course of about 3 weeks. If the immunodiffusion is negative, but your initial ENA was positive or this EIA was positive, then this is considered, we would consider this a negative test and not consistent with a SCL70 or scleroderma antibody. We see a lot of false positive RNP antibodies on our ENA as well. RNP we often think of as part of the diagnostic criteria for mixed connective tissue disease, although it's not specific for this. We can see RNP in multiple other diseases as well. Historically, in like historical criteria, you needed a high titer RNP. Our lab only does it by a multiplex bead assay. We see a lot of these where their levels are quite low. So on the multiplex bead assay, less than 1 is normal, 1 or greater is flagged as abnormal. We get a lot where the ANA is negative and then the RNP flags as abnormal. You can actually call the immunology lab and they will give you the level of the antibody, and we'll call, and it will be a level of 1.1. And if they're not having other symptoms and the ANA is negative, then we consider that kind of a false positive. Okay, so I'm just going to spend 2 minutes on treatment. So the American College of Rheumatology and American College of Chest Physicians came out with guidelines last year for treatment for patients with CTD ILD. They released I think it was last August, kind of flow charts of the recommendations. And actually earlier this month, the full manuscript was published, although I read through it. I don't think there's a ton of extra information, but besides what's involved in the charts. So first line treatment really for everyone should be immunosuppression, regardless of the pattern on the CT. So it doesn't matter if it looks more fibrotic or more inflammatory, immunosuppression is often in general the first thing that we try. Steroids, short-term steroids, so that's usually a couple of months of steroids, can be tried in most diseases, but there's a strong recommendation against using steroids in scleroderma, and that's because steroids above 10 milligrams of prednisone are associated with triggering scleroderma renal crisis, which has really high morbidity and mortality associated with it. Other recommendations for treatment are all low to very low evidence. And so it's really based on a patient's individual presentation, what medication we choose. And the order that they put these on in the guidelines was based on how many people on the voting committee voted for a specific medication. And there was pulmonologists and rheumatologists that were involved. So if you notice for rheumatoid arthritis, rituximab is 3rd in the first line treatments. But mycophenolate and azathioprine don't work for the joint disease in rheumatoid arthritis. So even though those are the first 2 first-line treatments, and maybe you use if someone has progressive lung disease or develops lung disease and their joint disease is well controlled, for someone who has active joint disease, those are not going to be great options. And so I often reach for rituximab in that case. They also have recommendations for what to do with patients who have progression. Notably, it's in the manuscript a little bit, but they don't include abatacept, which I often reach for in rheumatoid arthritis. But it goes through some kind of second line options that you can consider, including antifibrotics in rheumatoid arthritis and scleroderma. And then it has recommendations for rapidly progressive lung disease. So these patients, as we looked at, have a lot higher mortality. And so we typically use combination therapy for these patients up front. So IV steroids plus 1 or 2 additional therapies. And what you pick is, again, is really based on the individual patient, their risk factors, whether you're still ruling out infection, what you think they might tolerate, what goes along with their preferences, and what you think they'll kind of be able to follow up with. And I think that is it. So I'm happy to answer. I know that was a whirlwind of information. I'm happy to answer any questions people have.
Hey, Erica, can you hear me?
Yes.
I put one in the chat, and I guess it's relevant to the treatment. So it seems like clinically there's a bit of overlap between like some of the myositis that don't have a lot of muscular clinical symptoms and like some of the systemic sclerosis. And how do you like tease that apart? Is it just based on the antibodies? Because that seems like it has a lot of treatment implications.
Yeah, so it's based on the antibodies, and certainly people can have like overlap, like more than one thing going on. And then it's based on kind of their primary symptom. So patients who have sclerodactyly, I will call scleroderma and kind of treat them as such. If someone has a positive anti-synthetase antibody and sclerodactyly, I will use both. Similarly, patients who have like scleroderma or myositis and also have a positive rheumatoid factor and CCP, I sometimes will also call them rheumatoid arthritis. One, because they're more likely to develop erosive joint disease, which myositis patients do. So it kind of helps you know what you're watching for, but it's also helpful in terms of insurance of getting things like rituximab, since it's only approved for rheumatoid arthritis. So if you document that's what they have, then you can get the medication that you think they might benefit from. So
Okay. And then if someone's has like you think they have systemic sclerosis, but they've tolerated glucocorticoids in the past, I'm sure you know who I'm thinking of. Is that like, are you fairly safe giving them steroids again, or can you still get scleroderma renal crisis?
you can still get renal crisis. So the highest risk for renal crisis is in the first 5 years, and risk factors include steroid use, rapidly progressive diffuse disease, and that RNA polymerase antibody. So we typically still try to stay away from steroids if we can, unless someone has a life-threatening reason to use them. So I have certainly used them with life-threatening disease, but we really try not to, even if they've tolerated them in the past. We kind of say, that was great, you did well that time, but we're going to try not use them going forward.
Awesome, thank you. This was an extremely helpful review.
Any other questions? I know it's after 1 o'clock. I appreciate everyone coming. Perfect. Thank you all. Nice to meet everyone.